I think we can get started now, 12:05. So thanks everyone for attending the Jousse Lecture. It should be a really exciting talk, and thanks for everyone coming in person. The slides are going to be recorded, and they'll be put on YouTube later so you can watch them over again. So today we have a very exciting talk by Lovisa Cheung, who's a Postdoctoral Fellow at McMaster University, and we should be sharing this talk with Robert Burns, who's a PhD candidate in kinesiology at University of British Columbia, and they're going to also introduce themselves, which is quite exciting, so I'll let them just get into it.
Thank you so much, Damien, for the brief introduction, and also just wanted to provide a quick shout out as well. Thank you to Cesar also for allowing us to come to the space to present and to share some of the learnings that we've gained. So welcome everyone. Thank you again for attending our presentation on physical activity for aging adults with spinal cord injury. So Rob Guerin, who's connecting with us online, will be presenting with me in today's talk, and we're really excited to be sharing some of the barriers, the opportunities, and the lessons learned from our lived, our clinical, as well as our research experiences. So before we begin, I'd just like to acknowledge the lands on which the University of Health Network resides on. It exists on the traditional territories of the Huron-Wendat, the Haudenosaunee, as well as the Mississaugas of the Credit River. We are incredibly fortunate to not only be able to work and live on this sacred land, but also we acknowledge the lands on which McMaster University and UBC Okanagan exist, which allowed us, Rob and I, to prepare for today's talk. So as Damien mentioned, my name is Lovisa Cheung. I am a postdoctoral fellow at McMaster University, and my research focuses on facilitating physical activity for individuals living with spinal cord injury, with a specific focus on those who are aging. I'm also a licensed physiotherapist at the Hamilton Health Sciences, and I work at inpatient neurological rehabilitation. So again, really excited to be bringing together my research experiences as well as my clinical experiences in today's talk. And now I'll pass it over to Rob to introduce himself.
Hi everybody, I'm Robert Buehring. I'm actually a Lyndhurst alumni. I broke my leg in 2008, so I'm a T7 complete. But a few years ago, I started my PhD, so I'm in my fourth and final year of kinesiology, studying with Dr. Martin Guinness out of UBC Okanagan, and I'm trying to solve pain for spinal cord injury. So pleasure to be here today and share some of the stories of the work we did.
Thanks so much, Rob. And I will be flipping back and forth between the presentation, just so you can see Rob when he's speaking. But there may be some times where we might not be able to see you, Rob, just because of the way things are set up. So just wanted to give you a heads up about that.
No problem.
Okay, so thank you so much, Rob, for introducing yourself. So for today's talk, we really wanted to go over 5 key concepts. So we're going to start off by talking about the challenges associated with aging with spinal cord injury. We'll then talk about physical activity for aging individuals living with SCI. We'll talk about the importance of clinicians and rehabilitation researchers in promoting physical activity in a way that's safe. We'll touch on the role of remote exercise to promote physical activity and exercise participation. And we'll also talk about peer connection and the importance of collaborating with knowledge users, such as people with experience, clinicians, as well as researchers, of course. So let's talk about the challenges of aging, and I think it goes without saying that actually, based on research and our experiences in the rehab hospitals, the majority of people who are living with SCI in Canada are actually over 50 years old. So you can see from this figure here that the individuals who are admitted to rehabilitation hospitals are actually falling within the older age groups. So we have the average age of individuals living with traumatic SCI are about 54 years old, and non-traumatic SCI, the average age ranges from about 51 to 60 years of age. And so we know also that aging with SCI, especially with longer life expectancies, improvements in healthcare, people are aging with spinal cord injury, and there are many challenges that are associated with aging and spinal cord injury that span the physical, the psychological, as well as the social health domains. Some of these physical challenges include increased risk of vascular disease or markers of vascular disease, reductions in lean muscle mass, as well as increased incidence of shoulder pain, increased risk of pressure injuries, challenges with sleep and breathing, SCI-related pain, and of course, challenges with bone mineral density that increase their risk of increase these individuals' risk of experiencing a fracture. And these are just some examples of physical challenges, and of course there are psychosocial challenges associated with aging and SCI, such as increased risk of depressive symptoms, as well as social isolation. So I hope that sets the stage for the importance of examining, researching, and trying to improve the lives of individuals aging with SCI. So let's talk a little bit more about physical activity for this aging population. So currently we are on the second version of the exercise guidelines for individuals with SCI. So there were previous guidelines that were published in 2011, and now we're on the version that was published in 2018. And just as a quick snapshot to these exercise guidelines, there were 129 new references that were added to the update. There were reworded recommendations that were also included. And importantly, there were guidelines that were developed for specifically improving cardiometabolic health. The previous guidelines focused on guidelines for improving cardiorespiratory fitness/strength. These ones, cardiometabolic health guideline focuses on, of course, improving cardiometabolic health. So this table depicts the level of confidence of evidence of exercise improving various outcomes related to fitness, cardiometabolic health, and bone health. So really just as a snapshot, red means very low confidence, yellow means moderate, and green means high confidence. And so the main point of this table here is that just to show here that there was sufficient quality evidence to create the guidelines for specifically adults with chronic SCI, so those over 12 months post spinal cord injury, and also there was sufficient evidence to support guidelines for improving fitness and cardiometabolic health. So these are the guidelines. So as I mentioned, there are fitness guidelines and there are cardiometabolic health guidelines. I may not go into the details, but just by a show of hands, even in the room, has anyone seen these guidelines before? Look familiar? Okay, I'm seeing at least a couple. Yeah, the first, okay. So in the room we hear some individuals are familiar with the guidelines, some are familiar with the first version. So thank you. So what I wanted to highlight as well is that these guidelines mention how the recommendations may be appropriate for individuals who are living with acute or subacute SCI, those falling within the older age groups, and also those who are living with multimorbidity. However, there was one section that mentions that these individuals who fall within these groups should consult a healthcare provider prior to beginning an exercise program. And so this really just highlights the importance of clinicians and healthcare professionals in facilitating safe physical activity. So I'll talk a little bit more about this on the next couple of slides. So we talked about the exercise guidelines, and so what are some of the challenges that occur when it comes to exercise for this group, whether or not they're aging? And so, of course, there are aging-related challenges. There are challenges that are inherent to sport participation. And of course, as I mentioned, there are challenges that may become more apparent following spinal cord injury. But, there are many challenges when it comes to exercise for individuals with SCI, but I propose that it is important to strike a balance. Okay, so what do I mean by strike a balance? So we want to find that balance between recognizing the challenges of sports and exercise. So we don't want to scare necessarily people from participating, but we want them to be aware that there are risks to participation in physical activity, and there should be an eye to ensuring that they're safely engaging in physical activity. But on the other hand, there are many benefits, and so we do want to use our role, whether it's clinicians, rehabilitation researchers, or even caregivers or peers living with SCI, we want to also promote physical activity. And so I'm really excited to be here today. I don't think I mentioned previously that I was a previous trainee at University Health Network, so I've received lots of mentorship from individuals who have lots of expertise in SCI and also physical activity. And so I'm really happy to be back here in the old stomping grounds. And I know that a lot of you already understand the importance of physical activity. And so I know some of these things that I mentioned, I'm already preaching to the choir. So thank you for, and I think the fact that you are all here just reflects some of that interest and that value in exercise. So thank you for that. But I hope that there is something new that you can glean from today's presentation, even though I may be preaching to the choir. But importantly, you have an important role. So what I will do is I'll pass the virtual mic over to Rob just to talk a little bit more and set the tone for just how important exercise is, and especially the importance of exercise in the rehabilitation phases and being exposed to physical activity promotion as early as possible. So Rob, feel free to take it away.
Thanks, Lovisa. Yeah, just a little bit about me. So before my accident, going into 2008, my wife and I decided we were going to try to train for a half marathon. That summer I also got back into cycling, so I grew up on a bike, so I was happy to be back pedaling myself around. So it was just a few weeks before my injury that we did our half marathon, and then I had a mountain biking accident and broke my back. So I found myself at Lyndhurst, and someone that was another patient that said, I heard you wanted to be a triathlete before you got hurt. He said, well, you can still be a triathlete, you can be a para-triathlete. There's this guy in Ottawa named Chris Bourne. You can see a picture of him on the next slide. And I was online searching, para-triathlon. This came up, and I saw this picture of Chris, and I reached out to him, and I thought, oh, this guy, look, he's jacked. I mean, I want to be like that. If I can't walk, at least I have enough body now. But here he is, he's sitting in his hand cycle, so that's what he does the bicycle portion of a triathlon in. And he's holding up his racing wheelchair in his other hand, and that's what he just does the run in. And so another person that I met in rehab was Rich Vanderwall. A lot of people knew I liked speed and liked sports, and they said, you have to meet Rich. So when I did meet Rich, a lovely person who's become a dear friend, I told him, I said, I want to try this hand cycle thing. And so he's like, okay, I got you. So he went home, came back, and brought his hand cycle to my hospital room at Lyndhurst. And so I had this inspiration of Chris. And then the reality, which is the next slide, is, okay, this is me. So this is 4 weeks after breaking my back, but I sandwiched myself into this hand bike and away around Lyndhurst, I started doing laps. And I can't tell you what that, the power, that feeling of being under my own power and being able to know that, there's still sports that I can do, and I'm not going to end up just on the couch watching life go by me. And so you probably all familiar, there's that hill out back of Lyndhurst. And so just being who I am, I had to try it. So on the next slide you can see, going down was the problem, to get back up was the challenge, and I needed a push, which was totally fine. I have since gone back and conquered the hill, but I just love this picture because it reminds me, what, even 4 weeks after breaking your back, you can get out and start doing things. And I think that's really powerful. So in the next slide, the more you get into these parasports, the more you discover there's more and more technology always being adapted. This is my second hand cycle. It was a carbon bike. It's lower, it's lighter, it's faster, all these great things. The next slide, you can see, I wanted to go longer and longer distances, so I reached out to my friends, and they would take off work so we could go and ride all day. And it was amazing. I mean, I was getting that physical benefit of the cycling, but the social aspect of it was as great, if not bigger, but really powerful. And that sense of accomplishment of how far can I go and how long can I go and how hard. The next slide shows that particular day, you know, we did a 200-kilometer ride, so we went from my home past Niagara Falls and back in a day. It's like, okay, you know what, I'm getting better and better, I can do more and more. And just, you know, at the end of it too, the last slide, was just that celebration of, you know what, we can do things that are tough, and we do it together with friends and family. It's a pretty powerful thing. So for me, it was always, what's the next goal, what's the next goal, what's the next goal? And so I managed to do a triathlon in 2010, and then it's like, I just want to go long, I want to go long. So no Canadian paraplegia had done a full Ironman before. That's a 226-kilometer race. It's a 3.8K swim, a 180 bike, and then a marathon. So that became my uber goal that I was going to work towards. The next slide you can see. So we talk about barriers and opportunities. Well, this is me going to Europe to try to qualify to get to the World Championships. So the hand cycle comes apart and goes in that bag, that kiteboarding bag. The wheels are in a separate bag. I wrapped up my racing chair. It's like a little bit of a traveling circus, and I'm very fortunate my wife's a good sport because she had to do all the lugging around. But you know, there's these barriers, but you can't focus on them. You have to focus on the next thing. And so, the next picture, you know, I often tell people this is at the World Championships in Hawaii. Like, no one would go to Hawaii and lie on the beach for 8 hours because that would be stupid. But I was in that bike for 8 hours and 15 minutes to do the 180K bike and to climb a mountain. And so I was fortunate. I had about 20 minutes to spare before they would take me off the course to start the run. But I was just a marathon away, and so I managed to finish that race in 13 and a half hours. And I was only one of 2 out of 5 hand cyclists. I was with 2 of 5 hand cyclists finished that day. And you can see the next picture too, the finish line. So that was a big day for me, but also a huge accomplishment. And I think back, you know, to when I was in Lyndhurst and sharing the goals of what I wanted to accomplish, the things I wanted to do. And I was so lucky, and I think the best part of Lyndhurst for me was my physiotherapist. I had Jamie, and he got my number quickly, and he knew that I needed to be challenged, and he gave me the tools I needed to do that, and support, encouragement. And so I hope that everyone gets that kind of experience that goes through, because you're in such a powerful role to really define what's possible for the individual that just had this injury. And hopefully my story can maybe inspire you to remember that anything's possible. If I can do an Ironman with my arms, I mean, what else can anyone do? So that's just a little bit about me and my story, the power of sport. And so I was thrilled to connect with Lovisa on this intervention. Thanks, Lovisa.
Thank you so much, Rob. And we'll talk a little bit more about the so-called intervention that Rob was talking about. We'll touch on that a little bit later in our talk today. But really, Rob did a really great job setting the stage for, you know, his exercise journey. Not only started at his exercise journey post-SCI started at the Lyndhurst Center as early as possible following his SCI. So thank you, Rob, for being so vulnerable in sharing that. And so something that's important is that Rob is someone who's incredibly motivated, and he is someone who you know, values exercise to a great extent, which is part of the reason why he's been able to accomplish many of these goals. But something that I have struggled with over the course of my training here is, you know, involving the people who are not at the table. So one of the biggest challenges that I've encountered is, how do we promote physical activity in especially aging individuals who are not already active and who don't already value exercise? And that's something that I continue to, you know, wrestle with, and something that I'm still thinking about. But I'll also say that I do believe clinicians, rehab researchers, have an important role in facilitating and promoting physical activity in their clients who are living with SCI. And I hope that, you know, Rob, that your experience with Jamie also helped to push you a little bit further along in achieving your fitness goals. So here's the Proactive SCI Toolkit which is a resource that I find really, really helpful in promoting physical activity to those with SCI. And so I can't see everyone online here, but just for those in the room, has anyone seen this toolkit before? Does it look familiar at all? Okay, great. So there's hopefully something that can be taken away from today's talk. Really, really great resource. I'm not going to go through the entire toolkit, but this was a resource that was developed by Dr. Jasmine Ma, Dr. Kathleen Martin-Guinness, and also Dr. Shafetz from UBC as well as Hamilton Health Science. And as much as it says it's a physiotherapist guide, I strongly believe that it's not just something that's focused for people who are physiotherapists, but can be used by various clinicians and healthcare professionals. So this is really this is a snapshot of the cheat sheet that's included in the toolkit. And really this provides lots of information on how we can promote physical activity from the perspective of clinicians, and I would also say rehabilitation researchers as well. So there's various steps that you can take to promote physical activity. The first one being having that conversation. So we talked about your role, especially in the rehabilitation phases following SCI. You want to have these conversations as early as possible. You want to establish the importance of engaging in physical activity and working with your clients to accomplish and to meet their goals and meet them where they're at. So some examples could be having a conversation about their physical activity levels, talk about their goals for sure, and also the types of physical activity that they enjoy doing. You may also talk about, okay, what are the resources that they have on hand, whether it's in the community or at home, and then also have a conversation of what are some of the factors that may actually limit their ability to participate. So whether it's transportation, whether it's funding, and then taking those facilitators and those barriers and coming together to have a conversation to mutually come up with goals and strategies to facilitate their participation. And a lot of this can start actually in rehabilitation. And I know Charlene's here today, and she actually has a really important role in facilitating that at Lyndhurst, being a recreational therapist. So we're really happy that we have such a great team member at Lyndhurst here. Importantly, we talked about the physical activity guidelines, and I would say as you're having these conversations with your clients, your participants, your patients, you want to make sure that you're at least achieving at the minimum, the fitness and strength guideline, following the fitness and strength guidelines. So I've included it in one of the previous slides, but again, that's 20 minutes of moderate to vigorous aerobic activity twice a week, and strength training as well, twice weekly. So depending on where your client is in their motivation, so whether they're motivated or not motivated, whether they're ready or not ready to engage in exercise, you may pick a couple strategies and tailor it to where your client is at. So whether that be providing some education on, for example, exercise safety, the exercise guidelines, for example, maybe the benefits of physical activity. You may incorporate some behavior change techniques, which are all listed in the toolkit. You may also connect them with various resources that may be beyond your particular scope or beyond what you're capable of doing in your particular setting. So maybe that's connecting to other peers, maybe that's linking to other facilities or organizations, such as Spinal Cord Injury Ontario, Parasport as well. Lots of resources that individuals can get connected with early on. And ultimately, you want to make sure that you offer a tailored approach to meet them where they're at. So again, this is really just one of the pages in the Proactive SCI Toolkit. This toolkit is available online, and so I do recommend if you are working with individuals with SCI to take a look at the toolkit, and hopefully it will be helpful for you. So we talked about the challenges of aging, we talked about the scope of the SCI physical activity guidelines, just how important promoting physical activity is from the role of healthcare professionals and also in rehabilitation phases of injury. And now Rob and I actually want to share some of our experiences on how we try to ramp up exercise for individuals who are aging with SCI. And so we tried to promote physical activity in this population in a program that we ran last year. There's lots of challenges, lots of hurdles, but also lots of learning that happened. So on the next couple slides, we'll just share some of that information about the program. So we incorporated 3 evidence-based strategies to facilitate physical activity in our particular program. And again, this is not an exhaustive list of evidence-based strategies, but these are the ones that we focused on. And of course, I know I'm preaching to the choir. We know how important peer connection is. We know how important group-based exercises are for people with lived SCI experience, right? These group-based programs can provide a sense of community, but also involving people beyond just participants can also enhance the physical activity experience. Having individuals with lived SCI experience, of course those who are interested, as program facilitators, so leading a component of the program can potentially enhance the credibility of the information or the programs provided. So that was something that we incorporated. This is more in the research context, but involving people with experience as members of the research team, at least for us, and in research shows that it helps to ensure our work is as meaningful as possible for the people who we are working with. Again, another piece of information that I think will be reviewed for a lot of you. Adaptive sports are, of course, there's a lot of literature showing the physical, psychological, social benefits, so I won't go into the details of that and bore you. But I did have a conversation with athletes with SCI who fell within the older age groups, and they talked about how participating in sports later in their lives was important and had an impact for them. An example here is one individual who identified as a woman explained how, with aging, you have changes in hormones, you may experience changes in muscle mass, and so it is important to participate in physical activity, such as adaptive sports, to maintain strength and ability to transfer and be independent. Another individual had talked about prioritizing health over performance. And so there was one individual, I specifically remember he competed at the Paralympics, and he had described how previously it was a lot of performance-focused training, and now the priority has changed to lifestyle and really focusing on incorporating sports as part of the lifestyle for the long term. There were, of course, other points that were gleaned from our conversations, but just one of the advice that the athletes had shared was, if you go slowly, you'll go a long way, and that really just goes to show how it's important to gradually introduce individuals to sport participation, especially those who maybe within the older age groups or maybe don't have a lot of physical activity background. And of course, with the emergence of the pandemic, there was a surge of research on the role of remote programs. So there is research to show that services that are developed via telecommunication technologies, such as Zoom, MS Teams, etc., can help meet the needs of individuals with SCI who experience various transportation and accessibility issues. Not to mention as well, again, I know many of you are already aware that going from point A to B for someone who's living with SCI and maybe other conditions as well can be incredibly effortful and difficult. So these are just 2 examples of programs that were delivered, they're home-based programs delivered via teleconference. And these programs did show improvements in various physical and psychosocial measures. However, just want to highlight, these programs did not focus specifically on those who were older than age 50. And so with that in mind, becoming a little bit more familiar with the literature in these areas, it became more apparent to combine these approaches and see if there were any benefits or impact on the aging population. Rob and I were discussing this at a conference, I think in 2022, Rob, was that correct? I think it was in Vancouver. We were sitting at a table and we were thinking, okay, how can we create this program that's going to be accessible for individuals who are aging with SCI? And so that's what we did. We combined these evidence-based approaches, and we decided, okay, we're going to try, we're going to combine the evidence with Rob's lived experiences with hand cycling, and we're going to take a look and investigate the feasibility of peer-facilitated remote hand cycling, and also to look at the impact on physical, psychological, and social health within this population. So we, like Charlene, who's here, she was involved in this research as well, and so she had a lot of knowledge also on adaptive sports. So continue to learn. I continue to learn from her. I was really happy to be connected with her through this work. Dr. Kathy Craven was a huge mentor, especially for me, as I was and still continue to feel like a still learning trainee. I also received a lot of mentorship from her on the research and safety elements of this program. So just quickly, this was a group-based 60-minute intervention held twice weekly for 12 weeks. So we really tried to ensure that the program aligns with the physical activity guidelines. Me being a PT, I was most concerned about safety, so I was present at all the sessions. I led the warm-up exercises, and Rob led the remote hand cycling portion, which was a huge asset to our program. We ran the session on MS Teams, and we also used Swift to increase the fun element of the program. Just by a show of hands, has anyone heard of Swift before? A couple people? Okay, great. So for those who don't know, Zwift is an online cycling application where individuals can connect their bikes or their spin bikes, their road bikes on an instrumented roller, and they connect that to a screen. There will be an avatar that can be created, and these individuals, the users, they're called Zwifters, can actually cycle and compete against other Zwifters across the world. So, and you can really cycle in any course globally, and so it really does provide some visual feedback in terms of performance. So now I'll pass it over to Rob, because I've done a lot of talking, just to share some of the challenges and our journey to create this and come to this program.
Perfect. Yeah, when we met at ICOR, we were thinking different ideas, and the recent wheelchair was the first thing that came to mind, because I think it's just in everyone's mind, because you see it in Paralympics quite often. It's kind of a sport you see on TV. And so we thought about it and really sort of settled quickly that, you know what, this might not be the best way to do an intervention. It's crazy difficult to get in and out of. You've got to sort out your legs. It's difficult to push once you're in there. You need to wear these special gloves or blocks, and if you miss the rubber-coated rims, you're going to hurt yourself inside your arm. You need an indoor trainer. The cost of equipment is quite prohibitive. It's not a very social thing either. Your head's kind of hanging down after a while, holding your head up while you're pushing is quite difficult. So we moved on, and so we looked at the hand cycling. That one, next slide, it's still kind of challenging to get in and out of because it's almost on the ground, and you need to be careful with sorting out your legs. There's still a bit of a risk of pressure sores because your feet aren't in the holders for the pedal. You've got to make sure that your legs on the frame of the bike are going to be a problem. It takes a lot of space. These hand bikes are like 7 feet long. It's still an indoor trainer, costs equipment, it's expensive, well over 10 grand. But it's a great workout. And riding a hand bike is kind of like riding a home bike. It's a lot of fun. And it's very social when you can get out there. So we were kind of going on the right path, but having an individual hand cycle may not be the plan. So we thought about, hey, what if we took one of those sort of foot ergometer type tools? So Lovisa picked one up and dropped it off at my house, and I went through my bin of parts and I found a couple longer cranks. And I took them off the original one, I put these bike cranks on, I took the handles off my off-road hand cycle. And we basically turned this into a hand cycle type ergometer where the pedals are in line with one another. And then Lovisa took it from me, and then her and her partner figured out, let's strap this thing down. What does that look like? So we can tie it down around the desk. We can secure it. And even with the next step, we found a small portable desk that she was able to purchase to make a complete setup. And so what you see there, really, I'm really proud of what we came up with because it checks off so many of the boxes. The big one is an individual doesn't need to transfer out of their day chair to use this. So assuming that they're in a properly fitted chair or cushion, they can roll under and not worry about their skin. They just lock their brakes and away they go. It doesn't take up a ton of space. The cost of it wasn't too enormous. Technically, it could actually connect to the Zwift if you wanted to, but for us, we just used my Zwift account. But yeah, I think it was a win on many levels, and you can see from the next slide how it kind of put into action. The people that participated, I think, thought highly of it.
Thanks, Rob, for going through our journey in creating this program. And so this video just provides an example. I know this was just filmed on my dining table, so it's not like perfect in terms of ergonomics right now. But this is just an example, a sample of the program and how it was run from the homes of participants. So I delivered the equipment. I actually changed the height of the tables depending on the height of their wheelchairs and made sure that there was a proper fit, no areas of skin friction or anything like that, and just made sure the bike was a proper distance from each participant. So again, this is just how it was set up. They had a table, their bike was on it, and they had to connect to MS Teams through the laptop or through an iPad with their cameras on so that they can see the crew, interact with the crew, and also for, of course, safety purposes, which we had a number of different protocols in place to ensure safety for, of course, this population of people. So who did we get? We enrolled 5 individuals. As you know, we focused on individuals who are over age 50. And really, this table just goes to show how diverse the SCI related, and also the backgrounds of the participants that we enrolled. Really 2 things I wanted to highlight. Firstly, you can see here that majority, if not all the participants did participate and were living with multimorbidity or some other medical condition. So they did have to receive medical clearance from a physician prior to participating. The other point I wanted to mention is that all the participants were engaging in physical activity at the time of the intervention. So this was really the point. It's just it was an added layer to our program because this is where I learned that we did need to start thinking about, at least for future programs, how can we create a program that's low entry enough for people who don't already exercise to be interested in participating? So I can imagine there were many potential barriers to our program to target these individuals, but you can see here that the people who participated were already very motivated to be active. So as I mentioned, I was the most concerned about safety and adverse events. And of course, there were adverse events that were experienced, unfortunately. We tracked adverse events on a survey, and the participants were able to indicate whether or not, at least they believed it was, whether or not the adverse events was related or unrelated to the program. Several reported as unrelated. One was a fracture, unfortunately. This happened outside of the context of the intervention during the daily activity. So this participant had to be withdrawn from the program. There were instances of back pain, skin breakdown, AD, as well as muscle strains, one being related to the program. So in terms of management, we did address them by suspending hand cycling. Of course, we had the participant who was withdrawn and sought medical care. And the episode of AD was also addressed by managing bowels. And so these adverse events are actually consistent with what we already know about the challenges that people experience when it comes to physical activity and managing SCI. Bit of a busy slide here. Really, the main point from this table here is that we collected quantitative results and then we also collected qualitative results. So we had at different time points.
So I'm looking at the
Thanks, David. So we had collected data from 3 different time points, and we also interviewed participants. We had a conversation with them about their perceptions on the impact of the program on their physical, psychological, and social health. So we're really just mapping the information, mapping the outcomes onto one another. And so you can see here that there were mixed results, and a lot of the findings didn't show that there was change, and a lot of that might have been related to who we got and the types of outcomes that we used. But I would say what was really powerful about the study, beyond just the outcomes that we had, beyond just these outcomes, was the learnings and the experiences that were gained, the process of forming relationships and collaborations amongst all group members and various key interest groups. So whether those were clinicians, researchers, people with lived experience. So actually, I'll pass it over to Rob just to really, hit home a little bit more how important that collaboration was.
Yeah, it was great working together. It was kind of a funny story with the participants because we did primarily intervals for the sessions, and so I was trying to amp them up and get them going, get their heart rates up, and get some good work in, which was great. And Lovisa helped me out with that. But then during the recovery sessions, everyone just started talking about everything because it was just an opportunity for us to share stories and to connect. And so it was really kind of funny because it was like, okay, let's get back to work, let's get back to work. But overall, the experience was really, and I think the benefits for the individuals continue long term as well. So happy about that. And as clinicians, I mean, I've said this kind of previously, but also in other talks at the Jousse and other places, you're in such a powerful position to educate and motivate individuals. I think that's really key, and so I'm definitely grateful for that. Defining what's possible, and just a reminder that anything is possible. I mean, I did this Ironman with my arms. I think it's really important to make sure that if you're a person that maybe isn't into the triathlons or sports or maybe the faster kinds of things, that's really cool, but don't let your ideas of what's safe or fun or possible impact what the client might be interested in doing or wanting to pursue, because I think we can all surprise ourselves. So there's a bit of a lesson there, I think, that's worthwhile mentioning. The existing supporting communities are amazing, like Cycling Ontario and triathlon groups, and there's nothing better than, someone able-bodied pulling up beside you and cheering you on. But they do need guidance. So I found I'm often educating my coaches on how I work and what I need and what I need to be careful for, how my heart rate is going to be different because my heart's pumping blood through my legs and my legs aren't moving. So that's okay. So you can help the client give that information to a potential coach or someone else in the hospital. But the appetite is there, just maybe not the information that they need. Online communities like Swift, those are growing more and more all the time. It's good and it's bad. I mean, especially in Ontario with these winters. It's great that I can connect and be active all year long. And my metrics, with Swift, my watts are going into the computer, which is shown up on my avatar, and that's how fast I go. My heart rate, my cadence, my distance, my elevation, all that's, for me, that's someone wants to track it, it's there. And we're seeing more and more of that in different sports. And so have a look and see what's out there, because every day there's something new coming online. And the resources, handcycling.ca is a great one. I'm one of the founders of that. We're trying to get more people out. In a couple weeks' time, we'll be up at Horseshoe Valley. So if you've got clients that have seen an adaptive mountain bike and want to try one, we'll be up there helping people get onto these bikes and let them go around the parking lot to experience that. It's pretty powerful. So you can reach out to me and I can share some of that info if you haven't seen it already. But yeah, lots up there. Ontario, SCI, of course. plus resources are great. Thank you.
Thanks a lot, Rob. So going into the last really couple slides of today's talk, I'm more of a qualitative researcher. I love to chat. I love to talk to people. And so what we had done as the last phase of this program was to really hear from the experiences, not only of the participants, but also of some of the people who were involved in the delivery of the program itself. So one of the individuals had talked about how the procedure and the process of working together from various backgrounds helped to, was a meaningful part of the experience, working from beginning to the end. Another participant had talked about how our remote sport program helped to facilitate health equity, because people were able to connect from wherever they were at. We also allowed participants to connect with the equipment they had. So we had one person who owned their own hand cycle connect to our program as well. Beyond that, the program helped to also debunk some myths associated with aging. So one participant thought, okay, well, once you hit a certain age, you can't gain muscle anymore, but they believed that they were able to gain some strength from the program. And then lastly, and Rob kind of talked about this already, but the social aspect was a huge portion of our program. So it helps make the exercise easier, right? Makes the time go by. Rob and I, we had to play some good cop, bad cop as well. The participants worked really hard during the hard intervals, but also during our recovery time. Sometimes they get, a little chatty, maybe a bit too chatty. So we had to make sure that we were balancing that community aspect with, okay, you're going to get a good workout in, you need to work hard as well and stay focused on our task. Some of the participants also stayed behind to chat, talk a little bit more about how they felt about the program or about life in general. And it really just goes to show that the program itself, it extended beyond its research. A lot of the participants wanted it to evolve into something that was ongoing beyond just research purposes. So really just to end off, we talked about we talked about physical activity for this population, and really just to hone in on some of the key points that we'd like to emphasize is you as clinicians, researchers, potential caregivers or peers with lived experience, you have a role. Balance physical activity promotion with physical activity safety. Something really important to me is building relationships. So involve not only people with lived experience, but caregivers and various key interest groups in the work that you're doing, whether it be clinical work or in your research. And the last one for me is be creative. So don't be afraid to think outside the box in ways that may be unconventional to what we've been accustomed to when it comes to physical activity promotion. And I'll pass it over to Rob to close us off.
Yeah, I had 2 points left, which one was the more I get out there doing my research as well as being with the community and my lived experience, the more and more I'm seeing people needing rehab, and they're not using a manual chair, they've got a powered chair or an add-on. And the same with transfers. When I'm in the outpatient, they're always asking me if I want to do the lift, and I'm just kind of surprised that so many people don't have the confidence or strength to transfer to the table. And I just want to share that my experience was, if I've ever had to take off, let's say 4 weeks of sport for whatever reason, that's when I feel worse. Like, I would truly believe that motion is lotion. The more we can move, the more we can build muscle, the better it is going into my 50s and my 60s. And I want to wear everything out as opposed to have it not work for me because I didn't train it. And so it's just a personal reflection. I want to leave that with you. And then the last point is just a thank you. When you break your back and you're in this hospital, your life is upside down and you don't know one thing from the next. All your personal care, where you're going to live, maybe your job, your spouse, whatever. And I'm not sure if clinicians always get the love that you deserve. So just for me, and maybe on behalf of others with this, after we can get home and settle ourselves and look back, I just want to thank you for all the things that you taught us, how you kind of helped us get our independence back. So great job, and thank you. And yeah, when in doubt, push someone harder to do the impossible. So that's my hope. Thank you. Thanks.
Thanks a lot, Rob, and thank you to everyone, both in person as well as online, for listening to our talk today. I know some aspects were really preaching to the choir, but we thank you for sticking around and for your open-mindedness. Rob and I would love to collaborate, we'd love to chat, so our email addresses are on the slide here. But other than that, thank you again, and I'm happy to have any discussions for our remaining time. I know some of you may have to get away now. Thanks again.
Yeah, so we have some time for questions, and Cesar, if there's any questions online, you can just jump in as well. Is there any questions in the room? And thanks for the amazing talk. Yeah, go ahead.
So what I thought as a restoration therapist, we do the assessments and so forth with our patients, and I find that age, even though that's the age is 54, but that age, they say, I did that when I was in my 20s. I did sports when I was in my 30s. I want to go to a fitness center or a gym, but sports, they're not interested in as of yet, just because also they're thinking a lot about getting home, getting all their equipment, the cost of the equipment for the sport. So from my perspective, I have some that I meet and I get them right onto a hand bike or an all-sport chair, or I take them out to Variety Village to try sports. But a lot of times during the rehabilitation process, it's, you know, you're providing the information and the education, but they're not ready. They're not ready for it because of everything else that's going on in their life, because they're still in such an acute phase of their recovery.
Yes, I totally agree with that, Shirley. And, you know, as Rob mentioned, you know, when you're in rehab, you know, this is probably one of the most challenging points in someone's lives. So I do believe that clinicians just have a role even in, you know, planting that seed. It doesn't mean necessarily that you have to get them on, get them set up for the program like right away, but it's really having those conversations early, establishing that threshold, like, okay, you know, when you're ready, you may not be, you know, there's lots of information, a slew of things that are happening in the rehabilitation hospital. Maybe they're dealing with ongoing medical challenges or other issues that may be preventing them from participating to their full capacity. But I do believe that we have a role in, again, promoting that awareness, as you mentioned, giving them the education and the resources, and, you know, being a support to them. But I don't think necessarily that they need to, you know, be set up with everything right away before they're even at the point of being mentally ready or physically ready. So totally agree.
That's a big part why we provide that education. We bring in Parasport Ontario, we bring in OnPara, and those different organizations. We do tours of Variety Village, but a big part is the psychological part. It's that readiness of participating. The other thing that I found, which was really interesting, is we need to get these people more active. We want them to, if that's what they want to do, if that's their interest. But that's a lot of times when, if they've been in their wheelchair for a long period of time, they have shoulder issues, you know, they have like pressure sores, those kind of things. So that statement leaning towards having, you had 5 people for your research, was it in part because of that? Just because they had a lot of comorbidities, or?
In terms of our small sample size?
The number of people you had, yeah.
There were a lot of reasons why we had a small sample size. Well, actually, in talking about this,
I tried to recruit for you,
and we had a lot of challenges.
It's challenging. It was challenging to find that.
Definitely. And actually, a couple of the reasons why participants were not eligible to participate was because they were dealing with some issue that would have probably gotten worse if they started participating. Whether that was they were dealing with a pressure injury in a spot that was actually risky for them to have started hand cycling. There were upper limb impairments as well, or issues that they were dealing with, carpal tunnel. So some of those issues actually made them ineligible to participate. And something that one of the participants had mentioned in our interview or our discussion with them was that they were saying they believed that we had a small number because we excluded too many people for the safety reasons. And I'm not saying that it was necessarily right or wrong, or that I agree or disagree, but this individual specifically said they believe that we should allow them to make a decision whether they want to participate. I'm not saying that that should have been done, but it just goes to show that everyone, they just had their own perspective of they had their own perspective on who should be participating versus not. So we limited the numbers for safety reasons, but some of the participants, they had different perspectives. I'm glad we did, but it did reflect in the people who were able to recruit.
And then some people didn't meet that 50-year-old threshold by like a year or two, and I'm like, ah.
Yes, and the age group was also another issue. So we had another prospective participant who was interested, but they weren't turning 50 until I think like 1 or 2 months later. And so because research does operate within certain restrictions, so if we say, 50 years or older, we have to stick with it. But, in terms of, clinical practice in the real world, of course, you're, not going to exclude someone because they're a couple months off from whatever program you're implementing. But yeah, there were a lot of challenges related to people fitting in our very specific inclusion criteria. And of course, a lot of these I'm taking into future, I'm learning from it. And hopefully we can incorporate a program in the future that can be more inclusive and spanning larger network of people. Thanks for the comments,
It was
Shirley.
great work. It was great work. Very, very good.
Thanks, Shirley. I was very excited about it and what's to come. I see we're at 1:01, so I want to be mindful of everyone's time as well. I'm happy to stick around if anyone wants to engage in more discussion on this topic that I'm very passionate about. But otherwise, I hope you all have a wonderful day. Thank you to those online as well as in person. So thank you so much, everyone.
Yes, appreciate Robert and Lisa again, and we'll stick around here in person for a bit. If anyone wants to stick around for a few minutes.
Thank you so much, Rob.
Yeah, you're welcome. My last name, I can explain down. So the whole time you were talking,